These are some GU oral boards images. Let's first go through this. Patient 1, coronal T2 MRI. This is at the mid-prostate, so let's take a look at this. You see here your seminal vesicles. We have here the prostate, and here's the prostate apex. This slit here, this hourglass shape, is the genitourinary diaphragm, this space here. The distance between the arrows, between the prostate apex and the penile bulb, is visible on the coronal images. Also note that the external sphincter extends through the genitourinary diaphragm and into the prostate. So again, seminal vesicles, prostate apex, genitourinary diaphragm is this little space here. Here's the pudendal canal, the penile bulb. This is the same view. Prostate, seminal vesicles, external sphincter is here. The genitourinary diaphragm is here. The crura of the corpus cavernosa, and the levator ani muscles are these things here. Patient 3, coronal T2 MRI. Again, we're at the mid-prostate. You see the prostate here. Prostatic apex is here. This is the external sphincter. This is the genitourinary diaphragm here. You see the crura of the corpus cavernosa. Here, prostate. This is the obturator internus muscle. These are the levator ani muscles, prostate. Urethra is located here. This is the penile bulb. Note the median lobe as it pushes in the coronal. This is patient 3, sagittal T2 MRI, again mid-prostate. Here's the median lobe. Seminal vesicles are here posteriorly. Here's the rectum. Here's the penile bulb. Here's the median lobe again pushing into the bladder. The prostate here. Seminal vesicles posteriorly. Rectum here. This is the external sphincter. This is the urethra. This here is the penile bulb. Note the urethra in image 4 is not visible through the center of the prostate. However, it is visible below the prostate. Here's an axial of patient 4, T2 MRI, mid-prostate, prostate, rectum, pudendal canal. In image 8, the transitional zone and peripheral zone are apparent. Transitional zone is here. Peripheral zone is apparent here. Here's the rectum. Here's the pudendal canal again. This is the obturator internus muscle. This is a coronal T2 MRI at the mid-prostate. There's a transitional zone of the prostate, genitourinary diaphragm, levator ani muscles, external sphincter, penile bulb, prostate, genitourinary diaphragm, external sphincter, crura of the corpus cavernosa and prostatic apex. Note that the transitional zone is clearly visible in coronal MRI image 3, which is here. Also notice the short distance between the prostatic apex and the penile bulb. MRI apex to genitourinary transition. Note the transition from the concave levator ani muscles here at the apex versus the convex just below the apex. Concave, apex, convex, levator ani just below. So slit shape to hourglass shape. Ultrasound apex genitourinary transition. It's the prostate, apex, genitourinary diaphragm is here. Bulbal urethral gland. The apex genitourinary diaphragm transition on ultrasound is clearly defined in this example. However, in less clear examples, the external sphincter may be contoured as the prostate. Recognition of the light H shape, genitourinary diaphragm, or bulbal urethral gland indicates the genitourinary diaphragm. Notice the similarity of the genitourinary diaphragm on MRI and on ultrasound. Clarity, obscuration, clarity. Problem, CT of the mid-prostate, prostatic apex, and at the genitourinary diaphragm level. On CT, as contouring proceeds inferiorly, the prostate is clear above the apex, unclear at the apex, and mistaken for elliptical or circular genitourinary diaphragm elements below the apex. Summary of GUD shape. Image 1 is just above the penile bulb. Image 2, Image 3, and Image 4 at the apex. Note the change in the shape of the genitourinary diaphragm. Just above the penile bulb, it's triangular in shape. It is then circular, then hourglass shaped. These shapes are often more visible in subtle form on CT. Penile bulb, slit upper genitourinary diaphragm, levator convergence, apex begins at neck slice, lateral border is the obturator internus muscle. Avoid over-contouring the anterior fibromuscular stroma, and then a fiducial. Here's a case of a contoured prostate, AP, and lateral. This is an example of a good post-implant brachygeometry. Green is the urethra, red is the prostate, blue is the rectum. Note that this 145 dose line encompasses the entire prostate, which is the prescription dose, 100%. This is the 125% covered by purple. And then the actual prostate itself is in red. This is an example of a bad implant geometry, namely the slice. PTV is blue. The isodose legend here. Notice that 150% isodose line goes into the urethra, which is marked in yellow here. The 150% isodose line must never go into the urethra. The 100% isodose line, which is this kind of gold color, must cover the prostate, which is in red, and never go into the anterior rectal wall. So if the prostate is a solid line in red here, and the 100% isodose line is in gold, do we see that covered all the way around? Yeah, I think so. I mean, it dips in just right about there, and maybe right about there as well. This is an example of pelvic lymph node contours. So starting here, include both the common iliac artery and vein. CTV contour should exclude the muscle. Check for posterior vascular margins. This is carried down. Again, include the vein and the artery. The interspace between the vascular contours can be approximately 1.5 to 3 centimeters in width, depending on the patient anatomy. Sagittal, the contour should end approximately at the bottom of S3. Follow the pudendal and inferior gluteal arteries. Contour should extend 1 centimeter anteriorly. The medialmost portion of the acetabulum. Begin tapering off the internal pudendal artery as you reach the top of the seminal vesicles down here. The external iliac nodes should end approximately at the level of the external iliac inguinal vessels as they cross the most medial portion of the acetabulum or enter the inguinal canal on coronal views. So here the external iliacs terminate at the entry to the inguinal canal. Anteriorly extend approximately 1 centimeter to the anterior edge of the obturator internus muscle. Posterior edge follows the obturator internus muscle. And the obturator fossa contours when the seminal vesicles join at the top of the prostate gland or at the disappearance of the fat plane between the obturator internus muscle and the prostate gland, whichever is more superior. So this is post-op prostate contouring. The CTV fossa anteriorly. Superiorly, we'll say it's greater than or equal to 2 centimeters above the pubic symphysis. Include surgical clips and seminal vesicle remnants. Anteriorly, you want to cover the posterior aspect of the pubic symphysis up to the bladder neck, gradually coming off the bladder, ensuring that 1 to 2 centimeters of the bladder wall is located. Lateral goes to the obturator internus, and posterior is the anterior rectal wall. Inferiorly, you're going to go 8 to 12 millimeters below the vesico-urethral anastomosis. This can be approximated as the last slice where urine is visible. Your PTV margin is going to be 8 to 15 millimeters, except posteriorly where 6 millimeters is okay. Rectum, rectosigmoid flexure to the ischial tuberosities. Penile bulb is seen on sagittal view, and femoral heads include greater than lesser trochanter. So again, superior is greater than or equal to 2 centimeters above the pubic symphysis is where we start. You want to cover 1 to 2 cm of the posterior bladder wall. Extend out to the obturator internus and posteriorly cut off near the anterior rectal wall. Here's the obturator internus in orange. Again, carrying this down. We carry it down even more. It stops here. Here's the last slice. So vesicourethral anastomosis approximates this last slice where urine is visible. We carry this down 8 to 12 millimeters below that. This is a slide that reviews the different nodes. Mesorectal nodes are located about here. This is what it would look like on CT, MRI, and positive on PET. Internal iliac and obturator. Internal iliac, common iliac and external iliac, and then inguinal nodes here. Let's cover these fields. TE10 PA versus dogleg. Dogleg field, 10 centimeters wide in the para-aortic region. It usually covers the transverse processes. Superior border is usually the upper border of T10 or T11. The left renal hilum is included for left-sided tumors only. At the mid-L4 level, the field is extended laterally to cover the ipsilateral external iliac. Traditionally, the inferior border was placed at the superior border of the obturator foramen to include all external iliac nodes, but it is no longer. So the modified dogleg field superior border is the bottom of the body of T11. The inferior border is the top of the acetabulum, as can be seen here. The medial border for the lower aspect of the modified dogleg field extends from the tip of the contralateral transverse process of L5 towards the medial border of the ipsilateral obturator foramen. So you would carry that down to about here. The lateral border for the lower aspect of the modified dogleg field is defined by a line from the tip, the ipsilateral transverse process of L5, to the superlateral border of the ipsilateral acetabulum. The inferior border, again, is the top of the acetabulum. I believe the para-aortic fields are essentially from T10 or T11 down to L5. And you put 2 cm on the actual borders of the vertebral bodies or carry on the transverse processes.